you can make in gold medalist in psychotherapy if you don't have the that and then uploading the PPT. Just give me 2 minutes, okay? A therapeutic alliance in clinical practice. Very big words. What does it basically mean? So when we talk about psychology, psychotherapy, I think those of you who have even done psychology, even just in school, a simple question that comes in chapter 1 itself, which is psychology an art or is it a science? Is it a science? And the common answer that we all have is it's a combination of both, which means what gets missed out is that there is both art components, means there is a lot of art in psychotherapy, but it's not pure art, which means not somebody who's interested in psychotherapy can just do psychotherapy. We need to learn the science as well. Same way, psychotherapy is not only a science, which means just because you studied psychotherapy and you may be a gold medalist in psychotherapy, if you don't have the art, the actual skills required, you won't be able to perform psychotherapy well. So that's why it's called a combination of both art and science. Now, psychotherapy, counseling is basically involving interpersonal relationships, right? Interpersonal relationship because psychotherapy is between two or sometimes more than two individuals. More than two individuals when it's a family therapy or a group therapy or a support group that is being planned. But there always involves a minimum of two people where there has to be a safe space, a trusting atmosphere that is created so that there is communication between the therapist and the client. There is exploration of problems, exploration of underlying factors, moving towards a change, facilitating that change and growth. And this is not just for the patient, it's the therapist and the patient who work towards this together. So it's not the therapist is just giving gyan, is giving information, and the patient is automatically able to change. This is a process which involves both the client and the counselor, which is why the variables that determine how effective the psychotherapy is would be dependent on not just these two people, it will also be dependent on the setting, it will be dependent on the theoretical orientation, whether you're fitting, the therapist and the client are fitting with each other. Just because the therapy is not working out doesn't mean therapist is wrong or client is wrong. There's no right or wrong. They need to fit together in tandem for psychotherapy to be truly effective. Now, two important facets of this alliance, like I said, the relationship is comprised of the quality. So if I have to think of from a psychotherapist's point of view, what can I do towards the alliance? I can only ensure that I have certain qualities that help me build this relationship, and I have a supportive environment, which is the actual environment of the room, the kind of professional environment I am working in, all of those things put together, my mindset, my personal environment, all of that put together, which will contribute to the kind of relationship I develop with my client. Now, according to me, if I have to work as a psychologist, as a psychotherapist, as a counselor, whatever name you might give it, there are three important aspects that will always be there no matter which school of thought I am following. One is knowing my own self. Second is understanding other people. And third is being able to relate to other people. So I have put in 4-5 characteristics in each of these columns. So if you look at them carefully, when I have to know myself, I need to know a lot about my own strengths, my own limitations. So let's say, and if I do some disclosure over here, I mean, I think I would try and let you people know my own experience. I've been working as a psychologist now for 7 years. So for example, I know as a limitation that I am not very good at working with, let's say, addiction or substance abuse patients. And I know that as a fact, I have a very, very strong, I can say a bias or a judgment would be a little strong word, but it's true. And I need to be able to acknowledge that, wherein I do keep realizing that the individual is somewhere or the other having some sense of knowledge and insight of what he or she is doing and is still continuing to harm himself or herself. So I am afraid that as a therapist, I don't want that judgment or that bias to interfere with my work with that patient. So invariably, if I find a case of substance abuse or addiction where I feel like this judgment might be hampering my work with the patient, I would be free to recognize that limitation of mine and refer the patient to another psychotherapist. There is no shame in doing that. So knowing your own strengths and knowing your own limitations is extremely important. At the same time, you need to be confident and you need to have some self-respect as well. You need to respect the patient and therefore earn that respect from the patient. Specifically in the new years of working, in case we get very anxious, we need to know how to manage our own anxiety. Specifically, if it's a case which is making us more anxious, we need to manage that. If we don't manage our own emotions, it will interfere in our therapeutic alliance. There has to be an ability to trust. Like I said, patient has to trust the therapist. The therapist also has to trust the patient. And we have to have the courage as well as the commitment to counsel. What does that mean? It may not always be an easy task. It may have an impact on us. Whatever it is, we need to be committed to our field. We are here to help another individual reach a particular place that he or she wants to in their life. We need to have a collaborative common goal and help them work towards it, which we cannot do until we don't know ourselves, then understand other people and relate to other people. Understand others with an open mind, without any judgments, being as empathetic, being as objective, being as sensitive as possible. And how do you relate to other people? Not by faking it. You have to be very, very genuine. So let's say you're not able to understand something, you're not able to relate to something that a patient is telling you. Again, admit that. Say, I'm sorry, I don't think I understood that. Can you help me understand this a little better? But make sure that whatever you say, you're being genuine. You're not being very dominant over there. Active listening is something we'll come to. Unconditional positive regard, something a lot of you would have heard of, which means regardless of anything else, without any condition, you as a psychotherapist have some positive regard, have care, have genuineness towards your patient. And effective communication also, we'll come to this a little later in today's session itself. So, like I said, to sum up, this counseling relationship, this therapeutic relationship has major aspects of comfort, what we also call rapport. Unless this therapeutic space doesn't become comfortable enough for the patient to talk about the problems, there will not be a meaningful relationship. It will not be productive. It will not be effective. Okay. And secondly, we have to have a commitment. We have to be committed to the therapy. The patient has to be committed to the therapy, which can only happen with trust and respect mutually between both the patient and the therapist. And last of all, we also need to be committed that I am fully involved in this relationship. When I say a fully sharing relationship, it means that no matter what comes as a product of this relationship, both the therapist and the patient have to be committed to deal with that with a common purpose, with a common goal, with an empathy that stays consistent, and being able to understand and respect each other's responsibilities and duties. Okay. Now, the most interesting, simple and yet important part of today's session will be the actual techniques which we need to use. So like I said, the Therapeutic Alliance, the rapport that you form is usually in the first few sessions. So first day we discussed the clinical interviewing. Yesterday we discussed a lot of disorders. You might know all the interviewing skills perfectly. You might know all the disorders by heart. You might have all the classifications at the tip of your fingers. But if you don't have basic therapeutic techniques, basic counseling techniques, which I'm going to just run you through, you won't be able to sustain a few sessions. So what you're thinking might be right, but if you're not able to get the patient to come back to you for the next session, it's all gone waste. So these are the basic therapeutic techniques, which if you first master these and then use the next few years also to start building on your psychiatric disorders and their knowledge, you build on your interviewing skills, those things can still be added on. But these are still the underlying skills, basic counseling skills that you will need to get the patient to come back to you, to be able to make the patient know that there is a rapport, there is a relationship, there is an alliance that exists. Okay. First one, like I mentioned above, when you want to relate to others, is active listening. Listening means maybe hopefully what you people are doing right now, you are listening to whatever I'm saying. Some of you could be multitasking. Let's say you have it on, but you're doing something else and just hearing me. That is not listening. Okay. Now, listening is if you're paying attention to what I'm telling you. Active listening is you're not just taking in what is being said, but you're also responding back. And what are you responding back? You're giving a message back to the client that yes, I am listening to you without actually saying so. Okay. So active listening is without any judgment. Active listening is giving attention to the client when he or she is speaking. And it is more than just listening to the verbatim. You look at the body language, you look at the other non-verbal cues that are visible, you hear the tone, you hear the speed, you hear the pitch, you hear the language, you see the change in body postures, you see a complete picture. That is called active listening. In the next few sessions, it would also involve remembering what the patient said the last time. So the last time the person spoke about his mother, this was the way he was speaking. But today when he's talking about his mother, it's a slightly different way that he's speaking. That's part of active listening. You're not passively just sitting there and hearing the words. That could be the job of a tape recorder also. You are a human being. You are a psychologist. Okay. So here you need to be able to interpret. So even here, so a lot of times when this internship used to happen in the hospital, I would have a lot of interns sitting in with me, and I would ask them, what did you hear? And what best sense did you make of this session? First of all, they would tell me what the patient said, and they will try and give a diagnosis. Fair enough. That is, they were listening. Then I asked them, what more? What is beyond the actual face value of what the patient said? What were you able to understand? Then some of them would mention, ma'am, I saw that, he was very restless. He was moving his feet all the time, or, he was constantly sitting, aise aage hokar, he wasn't able to take the support of the chair at the back. So they would tell me what the body language is. That is the first step of observation. True active listening is when you're able to interpret what that means. So just because I'm shuffling my feet, is it because I'm anxious? Could be. Is it because I'm angry? Could be. Is it because, I'm having a pain in my leg right now? Could be. Is it because I don't want to be here and I want to leave? Could be. Or it could be another list of symptoms also. So active listening means I should be able to interpret that, and doesn't mean I'll interpret it right in the first go. It is a guess. But the guesses need to keep fitting into an overall clinical picture that we form in our head. Obviously, with more number of sessions, with more time that you spend with the patient, you will get more accuracy over here. These techniques that I mentioned, I will be coming to them right now. Second is clarification. So clarification means if just because the patient is speaking and our job is just to actively listen, we also need to sometimes ask questions if we are not able to understand. Like I said, there's no shame in telling the patient I didn't understand. You cannot be fake, right? You have to be genuine. So in case there was some confusion, in case there was some ambiguity in the person's thinking, in the person speaking, you need to ask. So I've given an example over here. So let's say the patient says, I can't get along with Sheila ma'am or Prateek, so I don't go to the class. In what ways does going to the class require you to interact with Prateek or Sheila ma'am? Well, since Prateek sits in front of me, it's pretty hard to avoid him, especially since he's always picking up fights with me. And since Sheila ma'am always takes his side, I always get caught in the middle. So instead of him just telling you that he is not able to get along with his teacher or a classmate, you need to clarify, you need to probe and find out what is the reason that is making him not get along with Sheila and Prateek. Okay. Third is reflection. A reflection is what? When you look at yourself in a mirror, you get a reflection. In psychotherapy, reflection is using an empathetic mirror. Empathy means being able to put yourself in the other person's shoes, being able to understand what the other person might be feeling, not just again the words that the person is speaking. Again, in all of this, remember, there's no judgment that can come in. We need to see what is the emotional stand of the person, what he or she might be saying, and try and reflect that back, because sometimes patients may not be able to actually label and identify their emotions. So, and not getting into details, but reflections also, you could have emotional reflections, empathetic reflections, and so on and so forth. But overall, I'm giving you an example of a reflection. So if the client says, I have been feeling bad lately, like I've done something bad. Like you've done something bad? I would just say it in that tone, for example. So the client says, yes, like I deserve to be punished. you feel that you should be punished. Again, the tone, the way that you respond to the child right now, it's not happening because I'm looking at a screen right now with my own face at it. But usually, when you're reflecting your non-verbal cues, the tone that you use, you're not saying anything new, but you're reflecting back to the patient what he or she said, along with some emotion in your sentence, right? This reflection could go to a deeper level where you're actually putting in emotions which the person didn't say, but we're not getting into that right now. Next is paraphrasing. Similar to the English grammar tool of paraphrasing, you're again taking the whatever the client said, taking those words and putting it in your own words, in different words. Again, just repeating what the client said using other words. Now remember, here you are not going to be becoming like a parrot and just constantly paraphrasing, right? Sometimes you'll paraphrase, sometimes you'll reflect. So these techniques, it's not that you pick one technique and it's going to work all the time, and doesn't mean all 13 techniques will be used in every session. There will be combinations of them. So for example, if the client says, I have not had enough time to study because of my work schedule and my grades are suffering. So the counselor can say, so it's been hard for you to keep up with work in school and you're concerned about your grades. So I have put it into my words that coping with work, coping with school is becoming a problem, and the concern is about your grades based on what the patient himself has told me. Next one is confrontation. Now again, like I said, each of these techniques cannot be used in every session. Confrontation is one of the relatively trickier techniques to use. It can be disturbing. It can backfire a lot also. So, but sometimes if you don't confront at all, your therapy will be stuck. You will not be able to make progress. So sometimes if you can see a discrepancy, you can see something that isn't matching, you can see there's some distortion, that some skills the patient is not being upfront with you, and there's something that you've been able to identify and you need to bring it up to the patient. How you do that is your technique of confrontation. So there's an example written, you can read it as I tell it to you. Client says, I would be studying for my boards now if I thought there was the slightest chance in the world that I could pass them. Really? Of course. Do you think I like this worrying day after day? Well, could it be that maybe all the worrying is in a way preferable to studying, because this way you're building up a case for your anticipated failure? Since I'm too anxious to study, I can't pass the test. It's better than feeling dumb, isn't it? Now, again, like I said, this confrontation could backfire also, but again, it's important. So let's say in this case, this person is not studying for the boards because he's so anxious that he may not clear them. And then he uses the fact that he didn't study as an excuse because I was anxious. Instead of taking the responsibility that after studying I wasn't able to, he has a fear that he will not be able to clear. So he has anxiety, which becomes a buffer because this way you're building up a case for your anticipated failure. Since I'm too anxious to study, I can't pass the test. It's better than feeling dumb, isn't it? Now, again, like I said, this confrontation could backfire also, but again, it's important. So let's say in this case, this person is not studying for the boards because he's so anxious that he may not clear them. And then he uses the fact that he didn't study as an excuse because I was anxious. So instead of taking the responsibility that even after studying, I wasn't able to, he has a fear that he will not be able to clear. So he has anxiety, which becomes a buffer for him to displace his failure on, right? So that is a technique which may work, which may not work again in this particular case, but that's what I'm trying to demonstrate, the technique of confrontation. Sixth one is probing, which is similar to the second one that we discussed, which is clarification, which is sometimes if the patient is not getting into details, you use this to increase the depth and the level of insight and understanding about what the patient is telling you. Again, don't do it too much, don't overdo it, don't overwhelm the patient. So for example, client says, I find that I just can't study even if I know that I'm going to fail the test. What happens when it gets down to study time? I get blocked. I can't concentrate. And the feelings at such a time are, I feel that I'm going to fail. Okay, so I was able to understand what is the client's feeling, which is not letting him study even though he knows that he's going to fail the test. That is his assumption. We'll come to that in some other days of the internship. Then is silence. Again, a very tricky one, very difficult to understand sometimes how silence can be a technique, but it is a very, very important technique specifically for us as new psychotherapists, right? You know, so we are taught that psychotherapy is about role plays, it's about this interaction, it's about these conversations, communication, what to say, what not to say. When we talk about silence, means what to do when you don't know what to say. And that's something I've been telling all my interns in these 7 years, something that thankfully some of my mentors also taught me, which is if you don't know what to say, if you're not sure of what to say, it's better you don't say anything rather than say the wrong thing. So saying the wrong thing could lead to a worse consequence than not saying anything. Okay, and sometimes this silence also is very, very empathetic. It's very, very reflective because it allows the patient to just analyze himself or herself what he's saying. A lot of times you're just the sounding board, so you just need to be there, and the patient will respect you for just being there rather than always wanting to reply back to the patient. Okay, and this also works the other way around. Let's say the patient is silent in the session. I have had a lot of sessions where the patient comes, sits down, introduces himself or herself, and then is silent. That means he or she is working through his own thoughts, his own feelings, is deciding how maybe to reach out to me. It might be difficult. Whatever it is, I need to be, as a therapist, be comfortable with that silence. And the patient also needs to feel comfortable. There should not be this sense of forced conversation that, listen, we really need to talk. So an example over here, client says, why do you think I am so upset about this test? Intellectually, I know I can pass it, but emotionally, why do I feel this tenseness whenever I have to take a test? So these are not questions that the counselor has to answer. It's okay if I'm just silently listening actively and just being there with the patient. Next is interpretation. Again, what this means in a psychoanalytical point of view, we will be discussing on a separate day, but simply as a basic counseling skill, it is to be able to explain back to the patient some pattern, some meaning which is underlying whatever he or she has been saying and doing until now. Okay. It sometimes could be part of an intervention, sometimes not, but it's a basic technique. So for example, client says, I'm sorry that I'm laughing at you. Don't take it personally. I can't help it, but I find you very funny looking. Whenever I think of you, I laugh. Now, in itself, it may not mean anything, but in a series of sessions, clearly there could be a value that could be behind this person's action of finding my face funny and laughing at it. So I can sometimes interpret that and help the clients, take the help of the client also to get to an interpretation. So perhaps it's really some other feeling that you're experiencing, maybe some anger or hopelessness. So you can ask and work towards an interpretation of what this might be meaning. Remember, in all of these techniques that we've discussed till now, and even the ones that are left, none of these are something that the patient is giving it to me and I am giving an answer and that is it. I'm not the final authority. Everything is being done in collaboration. So even if you're reflecting, you can always ask, I hope I'm getting it right. I hope I'm not missing out on something. I hope there's nothing wrong in what I've said. Okay? Oh, sorry. Yeah. Empathetic response, like I said, part of a reflection, part of active listening. You need to be able to help the patient feel that you are truly imagining or understanding the actual depth of that person's feelings. I am not feeling sorry for you. I'm not feeling bad for you. I'm not feeling happy for you. I'm feeling happy with you. I'm feeling sorry with you. And there are times it will be very difficult because we may not actually know what it feels like to be in that situation. So you don't have to imagine yourself how you would feel if you lost a mother, like your patient has lost a mother. You would need to put yourself in the patient's shoes, try and understand whatever you know about the patient's life until now, and then see what the patient is actually feeling like after losing his or her mother. Okay, and then you communicate that empathy, you communicate that understanding back to the patient. The client says, I feel like such a stupid idiot, such a failure. Everyone has a date to go to for the party excepting me. No one has asked me, and I know nobody's even going to. Since most other people have dates for the party and you haven't been asked, you're feeling rejected and left out. I can understand this hurts you deeply. So I've identified that there is rejection, that there is isolation, that there is hurt that the person is talking about, and I've put that into words and communicated it back to the patient. That's an empathetic response. There are times this also could backfire. So I picked on an emotion which, let's say, the person is not feeling. Be open to that. Am I right? So sometimes the person will say yes. Sometimes he'll reject your response that no, that's not how I'm feeling. That's okay. I'm glad to understand what you're feeling. So don't take rejection. So we can't have an ego as a therapist. Remember that. Okay. Then a very important technique is self-disclosure. Self-disclosure means when do you also reveal something about your own life? Why? So we need to be genuine. You need to be authentic. You can't be fake as a therapist. You can't use it all the time. You can't let the patient know every single thing about you, because then therapy will be about your life and not the patient's life. And again, we'll come back to boundaries. There needs to be a clear-cut boundary between a therapist and the patient. Otherwise, it could be the patient is talking to a friend and not a therapist. That's the difference, right? So sometimes you can go beyond the standard professional disclosure of just your name and your office address and policies. Anything that goes beyond that is self-disclosure. So what are the points to keep in mind when, if at all you choose to engage in self-disclosure? Before what is written here, one thing is that you must be confident, you must be aware of the fact that you're going to disclose, how it could impact this therapeutic alliance. Could it help? Could it backfire? If you're not confident, don't do it. Because if it backfires, you won't know how to deal with the repercussions. So invariably, this is a more experienced therapist who's able to indulge in self-disclosure, where you need to keep in mind how much are you telling, when are you telling, how much time are you spending on telling, how intimate and how deeply are you disclosing that, the timing, again, when you tell it. So all of these things, and you must know why you're telling, not just because you felt like it. There has to be a rationale in mind. So an example of a self-disclosure that has been used, a client says, I don't see how I will ever get over this hurt. I don't see myself ever getting back to normal. I know how you feel this minute. I lost my parents too. At that time, I didn't think I will ever make it through. It does take time, right? So when I have nothing else to try and empathize, but to add to my empathetic response, I can put in a bit of self-disclosure. Okay. Then we come to investigating alternatives. So again, when we are talking about clarification, when we talked about probing, this is another technique of getting to know more. Okay, getting to know more sometimes to understand the own patient's orientation of reality. It will help him or her change, and it will help him or her also understand whatever the choices that are available to him. Again, this is used a lot in motivational interviewing as a technique of therapy. So for example, the client says, since I was not able to get into any college, I guess I'm going to be a failure. I wonder what are the possibilities you might consider. Well, I guess I could pursue carpentry. I do love working with wood. Tell me, what do you know about getting a job available for the patient? You can't tell the patient what he or she needs to do, but you can explore the options. And the job of a therapist is not to make the person do something, but to facilitate the person to make his or her own choices for his or her own life. And you as a therapist are there regardless of whichever choice he or she makes. And you can maybe help the patient see what are the expected consequences of those choices, but you will still not be able to prescribe this or that choice. You will just be able to investigate and explore all those alternatives. Next, we come to the art of questioning. When you have to ask questions also, there are two kinds of questions primarily that you'll be able to ask. Open-ended questions are where there is not one particular answer, like even in your exams when you have your subjective questions, the long 5 markers and the 8 markers and the 10 markers. They require an explanation. So initially, when you want to encourage the patient to talk, you're using more of open-ended questions. What brought you in here today? How does it make you feel? Why is that important to you? How did you feel when that happened? What are your reasons? Do you have an idea why this is happening? And so on. The other type is the close-ended questions, where you can answer the question with a yes or a no, or with actual, accurate, or brief information. For example, what is your name? What do you do? Are you ready to stop doing that? Are you going to have the test tomorrow? Do you think you were right? What is your response to that? Okay, so this is getting into the actual details of a particular question. The last technique for today that we are discussing is summarizing, which is whatever, and this usually happens towards either the end of the session or towards, let's say if it's a 1-hour session, usually after 30 minutes of some conversation, you try and summarize, then you move towards the next phase of the session. So whatever the main ideas that have come up, you put them into your own words using paraphrasing. Sometimes it's shorter than paraphrasing, less detailed because you're summarizing a larger set of information. And here you're trying to give a background or basically an overview of whatever has been discussed in that session. You might add in some common words, some common knowledge about that topic from your own experience as an expert also. So for example, the client says, the client has actually shared with you over an entire session that she has recently been feeling depressed because of the breakup with her boyfriend. Okay, so the counselor could say, after what all we have spoken today, I see that the breakup has been hard for you and it's been affecting how you feel about everything. Simple summary. Okay, and then you move, of course, to the next phase. So those were the basic 13 techniques of basic counseling skills, of basically how to help work towards a therapeutic alliance. Now, what we need to understand is just these techniques are not enough, because therapeutic alliance needs to be cultivated and negotiated, which means it's not going to happen एक बार rapport बना लिया अब rapport बन गया. Rapport बनने में it will take a lot more time, but it's very easy. It can take a split second for the rapport to break. That's what we call a rupture in the therapeutic alliance. If you don't deal with that rupture, if you don't negotiate with it back, you will lose the complete therapeutic alliance, right? Which is why it's called a rupture, which means it can be repaired, it can be worked through again. So something to understand over here again, and again I'll give the example of interns itself. Whenever I have interns observing my session, I again tell them after they've observed a few sessions, don't just tell me what is being said, tell me how. So a lot of times when the interns sit in my room, they sit in a corner and yeah, sorry, I think you can still hear me. Just give me a few minutes till the PPT comes back, but I'll keep speaking. So this is again focusing not just on what the person was saying, but how. So when the intern is sitting in my room, instead of just listening to what the patient is saying, listening to what I am saying, try and understand what would ma'am be thinking that she said this. What would be going on in the patient's mind that the patient was saying this. That is called a relational matrix. Okay. So there are basically 4 steps which we need to involve in dealing with such a rupture. Just give me a minute, I'm trying to connect back so you can see the PPT. I am still here. Don't bombard with questions. Give me 2 minutes. I'm apologizing. There seems to be a thunderstorm outside, because of which the internet keeps cutting off. Let me see if I can put up the PPT here itself. I hope until now, today I'm not going too fast. There are also a lot of interruptions for you to also sink in whatever we are talking about. Yeah, I think I am now visible again, and I hope this doesn't get disconnected now this time from here. Just can somebody give me a thumbs up if I am audible and visible? Yes, I think I am. Okay, let me just go back to the slide we were at. Yeah, so like I said, focusing on not just the what, but also the how. So first technique is meta communication, which means you're communicating not just the what of what you're saying, but you're also going beyond that, being very mindful of what all is happening in the session when you're talking about the non-verbals and the calendar. Here, Mira. What do it? Click and join. Sorry. So yeah, you are communicating the implicit, the unsaid also. You're aware of it, you're keeping a tab of it, and you're also making sure that you're deliberately focusing on what is being communicated. That's called meta communication. Okay. At the same time, you're focusing on here and now. So you need to understand whatever is happening in the therapeutic setting, whatever is happening, it's not going to be staying constant. It's going to be constantly going back and forth, right? But you need to also remember, you can't only be thinking, oh, this is what the patient said, this is what the history was, this is what the background was. You need to be able to focus on the here and now. Okay. You need to be having an experiential awareness. While you're experiencing the session as a therapist, you need to not only be intellectually thinking of, again, the words that are being spoken, just the thoughts, you need to also have the emotions. You need to have the abstract sense of the holistic picture. This is something that will come with time, but until you don't train yourself, you don't prepare yourself to be focused and looking out for that, it's very easy to miss it out. And Last, like I've been saying, there needs to be a sense of collaboration, which means it is we who are working together. So a lot of times, sometimes when I'm talking in therapy also, I don't say in the next session, you will talk about this. I would end up saying in the next session, we will talk about this. So which means at the same time, I am also putting in my responsibility that I am also going to be contributing to the action. My job is not just to hear what you're saying, right? Participate, accept your responsibility. Like I said, the courage and the commitment to counsel needs to be there. And again, sometimes in that collaboration, like I said, there would be self-disclosure, there would be all those 13 techniques that we discussed. So your own experience also would be part of this collaborative process. And like I said, in those 3 columns of being a therapist, relating to other people, which involves relating to the patient, involves reflection, it involves empathy. You need to be aware of what's happening in this relationship. How will you identify a rupture if you don't know? So let's say suddenly the patient's relatedness has gone less. There's been a sudden shift. Either it could be overly related or it could be under related. Unless you're not on the lookout for what is happening, has your intervention actually been helping? Has it been facilitating? Has it actually been interfering? Is it working? Is it not working? Okay, so you need to understand, have you got a clear understanding of the patient's experience or not? So you need to constantly monitor your own understanding of what's going on and the patient's understanding of what's going on. So how do you deal with these ruptures which happen in your therapeutic alliance? Now, something to remember is a therapeutic rupture is inevitable. You're not a machine, you're a human being. Even machines, even technology gives way, right? You're a human being. You're trying to understand another human being. There are so many dynamic factors at play over here, right? So it is not just your fault if a rupture happens. It is not just the patient's fault. It is actually nobody's fault. It's bound to happen. But the patient also and the therapist also needs to have faith and trust in the process of psychotherapy, which means that if you're feeling stuck in the process, you need to talk about it. You need to what? We'll come back to that. You need to meta communicate about it and therefore negotiate this rupture. How do you do that? An example of a rupture is withdrawal. Withdrawal means the patient has taken a step back from the relationship, from the therapeutic alliance that was there. How do you get to know that? It's called a withdrawal marker. So let's say the patient is being overly deferential to the therapist. Overly deferential means overly wanting to listen and do only what the therapist is saying, as if I'm trying to please the therapist. Or the patient could be becoming very passively non-responsive. Whatever you're saying, the patient is just saying, "Ha, okay, ha, okay," not contributing. Sometimes the patient needs to disagree with the therapist also. So withdrawal is when you see that suddenly the patient has shown some sense of withdrawal from what his previous rapport was with you as a therapist. What do? You need to pay attention to this marker and bring attention to that, disembed it from the alliance and bring it up to the surface. Okay, which means, for example, and this rupture could be from my side also. So the example I've given is that maybe my attention wandered in a session. We're also human. It could be that my phone buzzes. Usually phones obviously have to be on silent and you should not be paying attention to your phone. But let's say there is something that you realize that on your personal phone, you're constantly getting calls from your family. And supposing your attention has gone there and you get distracted for 2 minutes and you can see that it's impacting your therapeutic relationship. You need to not just ignore it. You need to bring it up, which means I'm aware my attention is wandering and I'm not sure what's going on, but I think it may have something to do with a distant sound in your voice. So here it's not because of a phone ringing, it's actually because of maybe it's something in what you are saying that because of which the inattention is happening. So any sense of what's going on for you right now, so you bring it up to the table and you talk about it. Supposing it was just a phone ringing, I can actually apologize about that also. And I'm aware my attention wandered. I'm really sorry, but there seems to be a personal call coming. Do you mind if I quickly just put that on silent and come back so I can get back to it? Or I'll just drop a text and then get back to you. Be honest, be genuine. You're also human. But if you don't pay attention to it, you let your attention wander and you don't bring it up in that session, you're not dealing with the rupture in your therapeutic alliance. Once you bring it up, once you meta communicate about it, there are two kinds of pathways that might open up. One is where there's an experiencing pathway. So if I'm talking about the same situation, that where it is because of what the patient said, that there was a lack of attention, right? So at that point of time, there would be a sense of wanting to know more, wanting to experience why this happened, and wanting to tell more. That is an experiencing pathway. Versus an avoidance one where I don't want to get into the reason because of which this rupture is happening. I don't want to talk about it, and I will just explore it. You can try and empathize with me, but I'm not going to tell you why I'm feeling that particular way. Okay, so I'm aware that you're shifting the topic. Do you have any sense of what makes it so difficult to talk about what I mentioned? So if I'm going to avoid, I'll say no, I don't know. If I'm following the experiencing pathway, I'll say, yeah, I'm finding it very difficult to talk about it because, you remind me of my father, and, these issues which I'm talking about also were with my father. So whatever, and then we'll get into exploring that in a more in-depth manner. Same way, the last type of rupture that could happen would be if it is happening uh, because of confrontation. So like I said, confrontation is something that is a tricky situation in any case to use as a technique also. If you sometimes have a confrontation that backfires, that's when also it could lead to a therapeutical rupture. So again, understanding the confrontation marker where maybe the patient is arguing with you, defying you, constantly disobeying whatever the collaborative goal that was made as a part of the session, not respecting what the rules and the timings of the session was. So that's some kind of confrontation or resistance, what is called in psychoanalytical terms, that is coming up. So first you identify what is the marker. Second, what do you do? Same like we did for withdrawal, you meta communicate, which means you disembed it and bring it up to the table. I communicate to the patient by saying, it feels like you and I are in a power struggle right now, with me trying to hold you responsible for your frustrations with therapy, and you are trying to pin the blame on me. So I've put it into words and brought it on the table so that we can pay attention and try and work through this. Again, when you work through it, you will again have two parallel options that will come out, which means either the patient will get into actually experiencing the reasons because of which the confrontation is happening, or I might completely avoid. I don't want to get into a fight. I don't want to feel vulnerable. I don't want to end up crying in front of my therapist. So I will just go on the avoidance pathway. For example, my sense is that you began to contact some sadness there and then suddenly shifted into a harder or more aggressive stance. Did you have any awareness of this? Again, if it's an avoidance, a person will say, no, I don't think so. It's experiencing, yeah, and then we'll explore maybe why that change happened. Okay, now we're coming towards the end of the session. So, a common mistakes that are being made by therapists, specifically in dealing with these therapeutic ruptures. One is, let's say the first time I brought up a confrontation on the surface, or I brought up the fact that my attention was wandering or some withdrawal happened, and let's say it's not received very well, because it's a very, very challenging thing to do in that moment of time. You're actually, again, your entire therapeutic relationship is at stake. If this doesn't go well, you lose the entire hard work of both of you put together towards that therapy. Your entire relationship would be jeopardized. So yes, there is a risk. There always will be a risk. That doesn't mean you don't bring it up. You need to deal with it. If you ignore it, you're definitely going to have problems. Second mistake often the therapists make is that you forget to monitor the quality of responsiveness. Responsiveness of the patient towards the therapy, responsiveness of the therapist also towards the therapy, right? And remember, it's not that the first time, again, like I said, एक बार आपको बन गया doesn't mean जिंदगी भर बना रहेगा. कभी भी rupture हो सकता है. You need to be constantly monitoring yourself and the patient, which means there's a lot of thought that needs to go in for each session, even after each session is done, even during the session. So it's a lot of tiring work. In the session, you need to be having all your senses up there. You're actively listening, you're following all those 13 techniques, you're also saying what to say, what not to say, and you're monitoring all the responsiveness, relatedness of the patient as well as yourself. But also remember, as clinicians, we will make mistakes. All these mistakes have to be viewed as a learning opportunity, and use each mistake within the therapy. So I always, whenever I identify a mistake, sometimes it works, sometimes it doesn't, but I always bring up whatever I have identified within my session. Why let it go? Bring it up meta communicate about it. Let's try together to understand why they happened, how they happened, who contributed, how experience of that mistake, so that we can end up working through it and not just brushing it under the carpet. Okay. Last most important factors, which are the crucial, very, very crucial parts of a therapeutic alliance or the relationship. Like I was talking about, boundaries. Boundaries, like you have a physical boundary outside a house, you have to have actual psychological boundaries between the patient and the therapist. There has to be psychological boundaries across the entire therapeutic space and the entire world. So you need to understand that the relationship between the patient and the therapist is very intimate in nature. The conversations that you all are having, the patient is unable to have with anybody else, and of the nature that you're having them. The kind of professional relationship and yet so personal, it's a unique relationship, right? Both of you are committed to healing, but you need to make sure that there is no abuse happening. Abuse even emotionally, even psychologically, of either one of you, right? So boundaries are basic expectations which you need to decide in advance. You need to talk about them, you need to discuss them, you need to agree upon them in the beginning, and they need to be accepted by the patient and the therapist. What is my appropriate behavior? What is the patient's appropriate behavior? So even let's say in this internship right now, when so many of you message me that I'm managing 8,000 interns. So when I am telling you just now in the session that I will not